A very good evening to everyone. Welcome back to Medical Concepts. This is Shubham. So in this video we are going to talk regarding the liver pathology, and then we'll be talking about the kidney pathology. Both of these topics are very important as far as exams are concerned. So let's get started with the liver pathology first. So starting with the question number 136, histological examination of a dead man who had received numerous drug injections had shown a hydropic hepatocytes dystrophy. Okay, and lustreless glassy hepatocytes are seen. Acidophilic Councilman bodies, Councilman corpuscles, and lymphocytic macrophagic conglomerations in the portal tracts are there. And what is the most possible etiology of the disease? So Councilman body, however, the spelling is not correct over here, but who cares? It is started with C, and you must have read in the textbooks with the COU and CIL, right? But yeah, who cares? Councilman bodies mainly are found in the viral hepatitis B infections, most probably and most commonly, I will say. And generally overall you can say that Councilman bodies are a classical feature of the viral hepatitis. Okay, to be more specific, I will say viral hepatitis B. Okay, so no doubt about that. So here also they are asking you what is the most possible etiology of the disease. So a very easy question which they could have asked as far as liver topic is concerned. So here the answer is very clear in front of you, that is the viral hepatitis, and most of you are aware about that from your knowledge of medicine and the pathology. Okay, so here what is the term this Councilman body? So these are generally the apoptotic bodies. The concept of apoptosis and necrosis. Okay, if you watch the previous videos, like initial videos of this playlist, so you must have an idea about the apoptosis and necrosis. Apoptosis means it's kind of a programmed cell of a death. So this is happening in the viral hepatitis B mainly, where the hepatocytes are undergoing the process of apoptosis, and whenever they are undergoing the process of apoptosis, those apoptotic bodies, we are calling them as Councilman bodies or Councilman corpuscles in the liver. Okay, of course we are talking about the liver topic over here. So I have inserted an image for you guys as always, so that better perspective can be seen of this Councilman body. So here you can see the these markings which I am doing right now on your screen. So these markings which I am doing, these are nothing but the apoptotic bodies, and apoptotic bodies means I want to say that as Councilman bodies. Okay, so these ones which you can see, little ones, okay, these are the Councilman bodies. Okay, so let me remove the markings so that you can really appreciate. Yes, so these blue ones, these blue markings, I hope you can clearly see them. So these Councilman corpuscles, I'm talking about this one. Okay, so let me mark for you. So yes, I'm talking about these ones. Okay, mainly I'm talking about this one, right? Okay, fine. So these are what? These are the Councilman bodies. Apoptotic bodies will be seen in the liver, and they will be surrounding themselves with the normal hepatocytes. Okay, so surrounding them there will be normal hepatocytes, but these bluish color bodies which you can see over here, they are the apoptotic bodies named as Councilman bodies or Councilman corpuscles, mainly seen in the viral hepatitis. Which viral hepatitis? Mainly viral hepatitis B. Okay, so I'm writing over here viral hepatitis B. Okay, to be more specific. Anyways, let's move further. Question number 137. A patient with chronic viral hepatitis died of acute post-hemorrhagic anemia caused by the hemorrhage from the varicose esophagus veins. Okay, autopsy has shown a sharply diminished liver. So liver is getting smaller in size and of solid consistence. Surface is microtuberous and microscopically thin loop net of connective tissue, and small false lobules are seen. What name the morphogenetic type of? Cirrhosis. So okay, they itself mentioned over there that they are talking about the cirrhosis. They are talking about the liver cirrhosis, of course, because as they are giving you the case of the liver. Now the thing is, how to know that which kind of problem is considering and which kind of problem is leading this patient towards the diagnosis of the liver cirrhosis or hepatic cirrhosis, okay, or whatever you want to call it. Sometimes we are calling that as alcoholic cirrhosis if the etiological factor is alcohol. Okay, anyways, in this case the patient is not having the consumption of alcohol according to this case, but the patient was having the history of the chronic viral hepatitis. Look, the cirrhosis is having a very long list of the etiological factors, okay, and among this list, alcohol is very famous one, I will say, or alcohol is it has been seen that it is very common in the patients of liver cirrhosis, in the chronic alcoholic disease. I'm saying, like chronic alcoholism, if the patient is taking the alcohol, let's say for 15 or 20 years, okay. So in those patients it is very common. However, here they gave you the history of the chronic viral hepatitis, and it leads to the post-hemorrhagic anemia because of the bleeding occurring inside the body, and then from where the hemorrhage was coming, that was a varicose esophagus veins, okay. What I am talking about right now, to get a proper idea, okay, you need to understand some kind of anatomy of the liver and how the different organs are connected to the liver. You should know about that anatomy, okay, and that's how you will be able to understand that how this varicose esophagus vein can lead to the cirrhosis in this patient, okay. Now let's talk about that first, and then they are talking about the sharply diminished liver and microtuberous surface is seen of the liver. Why is it so? Let's make a sense. Okay, so here is the diagram which I have inserted for you guys. So look, let's have some concepts regarding the liver, and first of all let's have some revision for the anatomy. So this is the liver which you can see, cirrhotic liver, okay. Why we are calling that cirrhosis, we will be talking about that later on, but let's say for now just keep that in mind that this is the cirrhotic liver. And let me talk about the blood supply first of all. As you know from the anatomy knowledge that 75% of the blood is supplied by the portal vein to the liver, okay. So here is the portal vein, okay. So here is the portal vein, as you can see, right? Here is the portal vein, and this portal vein is carrying how much amount of blood? Yes, that is carrying 75% of blood. One more artery, this is the vein actually, portal vein, okay. 75% of the blood is supplied to the liver, okay. 70% of the blood supplied to the liver by the help of portal vein. One more artery is going on over there, okay. Let's say this is the artery, okay. I will draw it with the red one. Let's say this is the artery, okay. Which artery I'm talking about? This one. This is the artery for an example, and this is the hepatic artery. Which artery? This is the hepatic artery, and this hepatic artery is also giving the blood supply to the liver. How much amount? That is the 25%. So 25% of the blood is supplied by the hepatic artery to the liver, and 75% of the blood is supplied by the portal vein to the liver. Now, okay, if your liver is working fine, for an example you people, and for an example in my case, what is happening? Our liver is working fine, we hope that. Now if our liver is working fine, they will happily accept this blood supply. 75% of the, actually they need the blood supply because several kind of functions has to do by the liver, okay. Protein synthesis and various kind of clotting factors and other kind of functions are there, the long list of the functions of the liver. So our body is solely depending on the liver actually, and if that liver is not working, definitely your body will not be able to survive, okay. And after all, we are having one liver, okay. Kidneys we are having two, and if you are having sometimes there is some problem in the kidney, and if the patient may live on one kidney, I mean, but the patient can't live without the liver because we are only having one. So over here 75% blood supply I am saying coming from the portal vein, 25% is coming from the hepatic artery. What is happening if the patient is having liver cirrhosis, okay, which means the liver is not working well, the liver is not working fine. Etiological factor can be anything, it can be alcohol, or in our case it is the chronic what was that? It was a chronic renal insufficiency, or what? Chronic viral hepatitis, okay, chronic viral hepatitis. So what will be happening? Liver cirrhosis happened. Now you can see several kind of dot appearance, several kind of dot appearance you might appreciate right now on the liver surface. What actually happens is, whenever you are having some kind of injury, after some days the injury will try to heal itself. Okay, and sometimes if the injury was somewhat bigger, of somewhat bigger extent, then it can leave scars, sometimes on the level of this surface, right? Over here what will happen, same thing will be happening. If the injury will be happening to that extent that it is having some kind of deep injury to the liver or something like that, in that case what may happen is that there will be the scar formation. Okay, first of all there will be the fibrosis in the liver, and then there will be the scar formation in the liver. But if the injury is happening to the liver again and again, what will happen? There will be the formation of scar again and again, and that scar will give the appearance of microtubules kind of appearance. Okay, or you can see microlobules kind of appearance, which you can see granulated kind of appearance on the liver. Okay, so here what they have wrote over here is that there was its surface is microtuberous, so they mean to say that the surface is having the granular appearance. Okay, so that is the microtuberous surface. Okay, I hope you got my point. That is the microtuberous surface. Why is it so? Because of so many scar formation on the surface of the liver. Okay, obviously if liver will try to heal itself, sometimes there can be the scar formation. If there is too much scar formation, which means there is a problem. Okay, if you are having 20 times fracture in your hand, okay, will your hand be able to move? No, first of all it is not possible, and if that is possible, your hand, you can imagine what kind of scenario will be there. Okay, so that is the case over here. So microtuberous surface. So this, the liver cirrhosis, by the way, this is the end stage liver disease. Okay, which means if some patient is having the liver cirrhosis, the only and only treatment which is left in front of us, that is the liver transplantation. Okay, that is the case. So okay, so that is the end stage liver disease. So over here what will happen, let's talk further. And I said that 75% of the blood supply will be coming from the portal vein, 25% will be coming from the hepatic artery. Moving further, you can see the branches also. Okay, this portal vein is the bigger vein. I told you 75% of the blood supply. So what that mean? That means this is carrying the blood from several kind of organs. That's why it is having that much amount of blood supply. Okay, so portal vein is carrying the blood from the spleen, portal vein is carrying the blood from the stomach, portal vein is carrying the blood from the pancreas also. It's not shown in the not shown in this diagram. Pancreas also. So from the superior and inferior mesenteric vein, it is carrying the venous drainage from the stomach side. From the pancreatic vein, it is carrying the venous drainage from the pancreas. From the splenic vein, it is carrying the venous drainage from the spleen, and it is collecting all that blood, and then it is giving its blood supply into the liver. Okay, into the liver. Hepatic artery, that it is a part of the abdominal aorta. Okay, and with the help of the celiac trunk, it will be giving its branch to the hepatic artery. That from the anatomy knowledge. Okay, now what will happen if the liver is working fine? Everything will be fine. But in our case, what is the problem? In our case, the problem is the patient is having the liver cirrhosis. If the patient is having liver cirrhosis, it will not be able to accept this blood supply because the liver is not working well. The liver is having the injury, isn't it? The liver is having the injury, so the liver will not work well. Now what will happen, that whatever amount of blood supply was coming over here, it will actually cause the backflow. It will actually cause what? It will actually cause the backflow. Due to the backflow, what will be happening? Why there is backflow? Because of this cirrhotic liver, because of the liver cirrhosis. If there will be the backflow of the blood, it will be backflowing into the splenic vein, so the spleen will be having the problem. Spleen enlargement will be seen. We can say splenomegaly will happen, right? If it will be going back into the stomach, what can we say? Ascites can be there. The ascites, extra amount of fluid in the peritoneal cavity, right? Backflow of the blood will be going to esophagus also, because esophageal veins are also draining into the portal vein. Okay, with the help of hemiazygous and azygous vein. Okay, lastly it will be draining into the esophagus vein, what you need to remember is that esophagus veins are also draining into the portal vein, right? Now there will be the backflow of the blood into the esophageal veins also. If there will be the backflow of the blood into the esophageal veins also, the veins will also get dilated. And look at the shape of these veins, shape of these veins. Okay, these are somewhat having the spiral shape. Why? Because of this backflow of the blood, right? And due to the backflow of the blood, all of them are having the problem. So your stomach will be suffering due to that. Ascites can be there, and your spleen was suffering, so due to the splenomegaly can be there. Liver is already having the problem. Esophageal varices can be there because of backflow of the blood into the esophageal veins. If the esophageal varices will be there, then esophageal varices might rupture, and there can be the hemorrhage from there. Okay, for example, in our case, there was the hemorrhage from the esophageal veins, so that was the varicose esophagus vein, varicose esophagus veins, right? So that is the problem over here. And you can see the diagram over here. This is the diagram for the esophageal varices, where the blood may spill out from these esophageal varices, isn't it? So that is the case over here. So what was the basic thing? First of all, liver cirrhosis was there, but backflow of the blood was happening into the portal vein, and this portal vein is having the backflow of his blood from the subsequent organs, for example, from the pancreas, from the spleen, from the stomach, from the esophagus, right? So portal vein is the main culprit over here. And why the portal vein is the main culprit? Because of this liver cirrhosis. Okay, so backflow of the blood will be happening in the portal vein, because most of the blood supply is given by the portal vein to the liver, right? So that's why it's a problem. So we are also calling that as portal hypertension, because of the more blood, because backflow of the blood will be happening into the portal vein, so portal hypertension, right? So this is the case of portal hypertension. Sometimes we call that as portal cirrhosis, because it is happening due to the liver cirrhosis. So finally we can come to the conclusion that what can be the case over here, that is the name, the morphogenetic type of cirrhosis. So what kind of cirrhosis that was? That is the that is the portal cirrhosis, right? That is the portal hypertension. Due to the portal hypertension or the portal cirrhosis, there was a portal problem, right? So that is the portal hypertension, portal cirrhosis, you can say. Okay, I took a lot of time, I know, to explain this kind of stuff, but this is actually very, very important at the same time for your future perspective also, whenever you will read this topic of the liver cirrhosis and the portal hypertension in the medicine, and for the Krok perspective also, because sometimes they can ask you from the anatomy side, and they can ask you from the pathology side, sometimes they ask you from the physiology side, and these kind of questions can come. So that's why I took some time to explain this stuff. Okay, and from this single question, many kind of questions they can make. Okay, because nowadays they are not repeating the questions. Fine, let's talk about one more question, 138 in the liver section. Okay, so autopsy of a dead man who had alcohol abuse for a longer time has shown a small solid microtuberous liver. So I hope you got the point. Microtuberous liver means they are talking about the liver cirrhosis, and moreover the history given over here this time is alcohol. Okay, so I hope you got the answer already in your mind. Microscopically, false lobules are small and separated by a thin layer of connective tissue with the macrophagal infiltrates. Hepatocytes are at the stage of giant drop adipose degeneration. That is the term which they are using, this fancy kind of term which they are using for the liver cirrhosis itself. What are the most popular diagnosis? We are already having the diagnosis in our mind. Yes, that is the absolutely correct, alcoholic cirrhosis or liver cirrhosis or hepatic cirrhosis. Why we are calling that as alcoholic cirrhosis? Because of the history of the liver, history of the alcohol actually, right? So alcohol cirrhosis will be the answer. Okay, so we have already talked about many things about the liver cirrhosis and the portal hypertension, all this stuff. So you are already knowing about this stuff. Okay, how is it the alcoholic cirrhosis? Okay, let's move further without wasting any more time. Let's move on to the kidney pathology now. Okay, so liver pathology was having these three questions, but these three questions can be asked in the molded form, so you should have the concept basically. Moving on to the kidneys pathology now, 139. Autopsy has shown that kidneys are enlarged, cortex is wide, yellow gray with the red impregnation, well separated from the murine marrow. Histological examination detected the excretions of the nephrolithium and podocytes in the glomerular capillaries with the crescent formation. Okay, phenomena of sclerosis and hyalinosis of glomeruli, stroma fibrosis. So guys, what is the crescent formation? Crescent, what is crescent? What do you mean by the crescent? Crescent means half moon, you know, half moon shape, how the moon looks, okay, how the moon looks, complete this kind of thing, okay, not completely like this but circle shape, right? Now if I'll be making half of it, no, that's not half, it actually looks like how it looks like this, okay, isn't it? That's the half moon. Okay, so this half moon shape is what? This half moon shape is what? This half moon shape is the crescent shape. Okay, so this is the crescent shape. Okay, this is the crescent shape. Understood? So that's the case. Okay, now they are saying crescent formation. So if I am talking about the kidney and I am talking about the crescent shape, which kind of problem, which kind of kidney disease am I talking about over here? Yes, exactly, I am talking about the crescentic glomerulonephritis. You must have heard about this term while reading your books, crescentic glomerulonephritis, or we are also calling that as rapidly progressive because it progresses very rapidly, very fastly. So rapidly progressive crescentic glomerulonephritis. But the problem is not even single option is having that answer. So that's the thing, that's the catch over here. If you even know the answer rapid progressive crescent glomerulonephritis, you should know the main things happening inside this kind of problem, this kind of glomerulonephritis. Okay, so let's talk about that. First of all, some other names of this rapid progressive crescentic glomerulonephritis. Yes, the other name is, we are also calling that as a subacute glomerulonephritis, that is the same thing. Sometimes if there is so much necrosis going on, so much irreversible change going on inside the kidney, we are also calling that as malignant glomerulonephritis. Okay, so malignant glomerulonephritis, subacute or subacute glomerulonephritis, or the rapidly progressive crescentic glomerulonephritis, they are the one and same thing, you can understand that. Okay, now let me talk about few words about the crescentic glomerulonephritis. Okay, so this is a syndrome where there is the accumulation of cells in the Bowman space in the shape of crescent. Okay, so this crescentic shape, which I told you, half moon shaped cells, they will be depositing in the Bowman space. Okay, and what they will be causing? They will be causing the oliguria, or sometimes anuria might happen. So this is the case of, so basically they are doing the kidney injury. That's why we are calling that as glomerulonephritis. So the glomerulus of the kidney, inside them we are having the nephrons, so inflammation of the nephrons in the glomerulus is the glomerulonephritis, isn't it? Now rapidly progressive because it is these crescent shape cells will be accumulating the space in the Bowman's space, and they will start to destroy the cells over there. That's why the problem is the rapidly progressive. Okay, so that's why it is rapidly progressive. Sometimes it can cause the irreversible renal failure, and in that case we can call that as malignant glomerulonephritis. Okay, so according to the histological picture, if you will be seeing this rapidly progressive crescentic glomerulonephritis, we will be talking about the histological picture. You will be seeing in the microscope histologically there will be the extra capillary proliferative cells, extra capillary proliferative glomerulonephritis can be seen. Okay, or you can say extra capillary productive glomerulonephritis or the proliferative glomerulonephritis. So over here they gave you the term with the E option, that is the extra capillary productive glomerulonephritis, or you can say extra capillary proliferative. That's what given in the textbook, proliferative glomerulonephritis. Okay, I will be providing the notes as well. You can give a read from there in from the description box. Okay, so no need to worry about that. So that is the extra capillary proliferative glomerulonephritis, where histological image, histological appearance. So first of all, you should know the diagnosis of this case. Diagnosis is very clear because they already mentioned about the crescent formation. Okay, so everybody will get the point that yes, this is a crescent formation, this is the crescentic glomerulonephritis, rapidly progressive. That's why they intentionally did not give that option in your this particular question. So they gave the option extra capillary productive glomerulonephritis because in the histological image in the crescentic glomerulonephritis that can be seen. Okay, some few more words about this one, that sometimes kidneys will be enlarged and they will be pale in color. Sometimes there can be the hemorrhages in the cortical surface of the kidney. Okay, so these kind of changes can be seen. And the main thing which I told you, that the crescentic shaped cells will be depositing in the Bowman space, that will be causing the rapidly progressive glomerulonephritis. Okay, so enough about this crescentic glomerulonephritis. Rest of the things you can get from the notes itself. Okay, so moving on to the next one, question number 140. Microscopic examination of the kidneys has shown the proliferation of nephrolithium in the Bowman's capsule. Okay, fine. Of podocytes, macrophages with the formation of crescent structures. So guys, again, if they are talking about the crescent structures, they must be talking about and in 90% of the cases they are talking about the crescentic glomerulonephritis. Now that compressing the glomerulus. Moreover, they are talking about the nephrolithium in the Bowman's capsule, which means yes, crescentic shaped cells are accumulating inside the Bowman's capsule, right, the Bowman space. Capillaries of the glomerulus are necrotizing this time. Okay, so very severe form of crescentic glomerulonephritis is seen over here, and glomerulus are affecting. Of course, there will be the sclerosis or the halitosis, and there's a dystrophy can be seen, infiltration can be seen of the nephric stroma, and name the renal pathology. The answer, crescentic glomerulonephritis. Okay, so not given in the option again. So what will be the answer? Malignant glomerulonephritis, because of that term, which is the necrotizing glomerulus is seen over here. And moreover, I told you the crescent glomerulonephritis, sometimes we are calling that as subacute or the malignant if there is irreversible changes or the necrosis happening in the kidney. So yes, that is a malignant glomerulonephritis this time, isn't it? Okay, moving on to the next one, 141. A 36-year-old woman died of the renal insufficiency. Microscopic examination showed the proliferation of the capsule nephrolithium. Again, proliferation of the capsule. Which capsule? Bowman's capsule. Okay, so their proliferation, which kind of cells are proliferating? Crescentic cells, right? They must have been proliferating over here. Podocytes and macrophages, again they are mentioned about the crescentic formation, isn't it? Again, the diagnosis is crescentic glomerulonephritis. Again, they didn't give the option of crescentic, they didn't give the option of malignant, they gave the option of what? Subacute. So do not confuse. Having several names, that doesn't mean that change the concept. Okay, the concept has to be same, the name can be different. Okay, and sometimes they catch you in those things, right? So get that right, subacute glomerulonephritis or malignant or the crescentic glomerulonephritis. Okay, if they will be giving the crescentic, it will be very easy for you guys, isn't it? So that's why they're changing the terms. Okay, 142 now. Autopsy has shown enlarged kidneys with the coarse tubular surface caused by the presence of numerous cavities with smooth walls filled with the transparent fluid. Okay, so the question in itself is very clear, that they are saying the kidneys are actually having the enlarged shape and they're having the numerous cavities on their surface with the transparent fluid inside them. So they are talking about the polycystic kidneys. Okay, and the full name is actually, this is the autosomal dominant condition, so we are calling that as autosomal dominant polycystic kidney disease. In short, we are calling that as ADPKD. Okay, what is ADPKD? We are calling that as ADPKD. ADPKD is, okay, I'm not abusing anyone, this is the ADPKD, means autosomal dominant polycystic kidney disease. Okay, autosomal dominant polycystic kidney disease. And I have inserted an image for you guys so that you can really have an idea about this. So you can have the look for the kidney, and these ones I am talking about, this one for an example, this one. Okay, many kind of yes, cyst cavities can be there, and inside them there can be the transparent fluid. This is the polycystic kidney disease. Because of many cysts are there, so polycyst, that's why kidney, because due to that disease will happen in the kidney. So polycystic kidney disease. So this is the ADPKD, autosomal dominant polycystic kidney disease. Because sometimes they might ask you same question and they will be giving you the options as is it X-linked dominant, or is it X-linked recessive, is it autosomal dominant, is it autosomal recessive. These kind of option might come. So remember this full name. ADPKD means autosomal dominant polycystic kidney disease. Okay, so here the answer is very clear. Polycystic kidney disease is not in the option as expected, so answer will be cystic disease, right? So answer will be cystic disease. Same thing, right? Autosomal dominant polycystic kidney disease is a cystic disease. After all, there is a formation of cyst with the transparent fluid, but the main appropriate answer will be the autosomal dominant polycystic kidney disease. Okay, moving on to the next question. Autopsy of a man who died of the burn disease has shown the cerebral edema. Cerebral edema. Okay, if I will be asking you the pharma link over here, cerebral edema can be treated by which drug? Yes, so remember that will be the mannitol. Okay, so if they are asking you the drug, okay, the pharma link, cerebral edema, that is the osmotic diuretic. Okay, so that will be treated with the mannitol. Okay, fine. Enlargement of the liver and kidney, the cortex of which is white and gray pale, medullary substances plethoric. Microscopically they are saying the necrosis of the tubules. Okay, necrosis of the tubules of the main departments with the destruction of the basal membranes. Okay, edema of the interstitium with leukocytic infiltration and the hemorrhages. What is the most possible diagnosis over here? But the main thing they said, yes, there is the edema of the interstitium, there is a leukocytic infiltration. Okay, there is the edema. Okay, but main thing they said that microscopically there is the necrosis of the tubules. If there is a necrosis of the tubules, which means the tubules are having not great time over there inside the kidney, isn't it? So what is this case? Necrosis of the tubules, tubular necrosis, acute tubular necrosis, AT, and acute tubular necrosis. In the Krok language, or in this outdated, I will say, standard textbook, they are calling that as necrotic nephrosis, but that is the acute tubular necrosis. If you will be reading this from the standard textbook, international edition, so that is the acute tubular necrosis. Okay, so that is the case, and over here the option as expected is not given as acute tubular necrosis, but the option which is given over here is the necrotic nephrosis. So that will be the answer. That's nothing but then AT and acute tubular necrosis. Now few words about the AT and how you can recognize the AT and case acute tubular necrosis in your question. Okay, that is the main thing. So acute tubular necrosis, actually, first of all, the kidney will be seen very enlarged. Okay, that is not new, because kidney can be enlarged in any other kind of case also, right? So kidneys can be enlarged and swollen, but the main thing over here, on cutting section, the cortex will be pale in color, but the medulla will be darker than the normal. Cortex is pale, medulla is dark. Cortex is the outer surface of the kidney, isn't it? Medulla is more inside of the kidney. So cortex is paler in color, medulla is darker in color. Main thing, first one. Second point, it can be, in most of the cases it has been seen that it can be happening inside the body due to some kind of infectious disease. For example, typhoid fever can cause that. In some cases, if it is severe typhoid fever, then due to the salmonella typhi, of course, and then it has been seen very commonly in the mercury poisoning. Okay, so remember about that very important point. In the mercury poisoning, it has been seen, mercury chloride poisoning or the mercury poisoning, that some kind of changes will be seen in the kidneys, and usually there is a necrosis of the tubules over there, and due to the necrosis of the tubules, that's why we are calling that term as acute tubular necrosis. So which poisoning? Mercury poisoning. So remember that in your mind, mercury poisoning can cause that. One change I told you that on the cutting surface, the liver, sorry, we are not talking about the liver, kidneys, cortex of the kidneys will be having the paler color, and the medulla will be having more darker color as compared to the cortex of the kidneys, right? Due to the mercury poisoning, how the necrosis will happen? So the epithelial cells of the PCT, they actually having the necrosis, okay, and due to the destruction of the epithelial cells, and they will be falling into the lumen and causing the obstruction. So necrosis will be happening over there. I will be telling you much clearly in the subsequent questions with the help of an image, but for now you can understand that epithelial cells of the PCT will undergo the necrosis process due to the mercury poisoning or due to any other kind of infection. Now these desquamated cells or the degenerated cells, they might undergo the dystrophic calcification because of the dead cells. They might undergo the dystrophic calcification will be seen in the dead tissues. I told you earlier in the videos, okay, of this playlist, you can check them out. Tubular basement membrane will be actually remain intact, but the main problem is happening with the epithelial cells of the PCT. Okay, they are actually undergoing the necrosis process. Okay, so that is the case. So here main generally you can remember that the necrosis of the tubules might happen in the acute tubular necrosis. Okay, as the name suggests, what we are calling that as necronephrosis or the necrotic nephrosis. Okay, rest of the details you can read from the notes in the description box below. Moving on to the next one, question number 144. 42-year-old man with a complicated form of the typhoid has had acute renal insufficiency developed which caused death. Autopsy showed enlarged edematous kidneys. Fibrous capsule can be easily removed. On the cutting surface, cortex is grey pale. Pyramids are murray. Histological examination have detected narrow lumen of the moist tubules. Okay, so cortex is grey pale, pyramids are murray, which means that more darker in color, and enlarged epithelial cells without nuclei, and the narrow lumen of most tubules, collapsed glomeruli, edematous stroma, and the small leukocytic infiltration, small hemorrhage. What pathology is meant? Some of the hint you already got in this point. For an example, first one, typhoid fever. I told you, I gave you the example, two examples, mercury poisoning and some kind of typhoid is very crucial. Typhoid fever. Second, they told you kidneys will be enlarged. I told you it can be enlarged in any other cases also, but the main thing, fibrous capsule will be easily removed. That's okay. On the cutting surface, I told you the cortex will be grey pallor and the medulla will be more darker. So pyramids are murray, means like medulla is actually having the darker color, and pyramids will present in the medullary region, isn't it? So cortex is grey pale, pyramids are having the more darker color. Narrow lumen. Why there is narrow lumen? Because of the necrosis of the epithelial cells of the PCT. Okay, they will be falling into the lumen of the tubule, and that's why they will be causing the obstruction, they will be causing the narrowing of the lumen. Okay, so that is the case of acute tubular necrosis. Not given on the option, no problem. Necrotic nephrosis or necronephrosis. Yes, that will be the answer. So necronephrosis, that is what? Acute tubular necrosis. Okay, that is the main term. Fine. Moving on to the next question. A patient has the patient with signs of mercury poisoning. So again they are talking about the mercury poisoning. In the last question they told you about the typhoid fever. In this question they are talking about the mercury poisoning. And following process in the kidneys, focal necrotic changes. So guys, focal necrotic change in the tubules of the main departments, and then edema, leukocytic infiltration. Obviously these cytokines will be these soldiers of this traffic, you can call them. So they will be coming over there, so to actually analyze where the accident actually happened, isn't it? So having the hemorrhages of the interstitium and the venous conduct, which condition develop? Acute tubular necrosis or the acute necrotic nephrosis, isn't it? Same, acute tubular necrosis, acute necrotic nephrosis, necronephrosis or necrotic nephrosis, one and the same thing. Now let's look at the diagram. I told you the PCT region will be having the hard time actually over there inside the nephron. So what will be happening? They will be actually having the destruction, and they will be falling down in the lumen itself and causing the narrowing of the lumen, isn't it? Narrowing of the lumen. That's what we read in the previous question, that there was the narrowed lumen of the most tubules, right? So that is the case over here, and due to this narrowing, and then leukocytic infiltration, edema will be seen, and all these things will be happening over here, obviously. So that is the case of the acute tubular necrosis, and here they gave you the term of mercury poisoning. I already mentioned about that. The mercury poisoning and typhoid fever can be the culprit in causing the acute tubular necrosis or the necrotic nephrosis or the necronephrosis, right? And if about this one, let's move on to the next question. Question number 146. Okay, in the renal biopsy material, sclerosis and the lymphoplasmacytic infiltration of the renal pelvis and the calyces. Dystrophy and atrophy of the tubules were detected, and the preserved tubules were widened and stretched by the colloid-like masses. Main thing over here is epithelium is flat, thyroid kidney, and now you must be surprised, thyroid, how the thyroid can present inside the kidneys, isn't it? The thing is, we are calling that as thyroid kidneys. Okay, pathologists call them as thyroid kidneys. Okay, thyroid is not going into the kidneys actually. Okay, but they are having the presence of appearance of the thyroid, so pathologist can name anything believe it or not, they can name anything actually, and if they have named it, you have to read that accordingly. So I have inserted an image that is actually seen in the chronic pyelonephritis. First of all, I will give you the proper perspective of the chronic pyelonephritis, how it happened, and actually what is happening in the chronic pyelonephritis. Don't worry about that, but for now let's look at the screen. And what I want you to show you over here is that is the thyroidization of the tubules. Okay, and this is thyroidization of the tubules. Actually, it is seen in the chronic pyelonephritis, and this is the finding which we actually appreciate in the tubules region. Okay, in the last concept I told you about the acute tubular necrosis, where the epithelial cells of the PCT were undergoing the necrosis process, isn't it? Here I'm telling you that tubules is having the change as thyroidization of the tubules. Thyroidization of tubules, what does that mean actually? Actually, in the tubules, some areas are showing the atrophy, some areas are showing the hypertrophy or the dilation. Okay, that's why we are calling that a thyroid tubule. If you will be seeing the thyroid gland, you can see some kind of cells over there. We are having the colloid. Okay, you must have heard about that in physiology while talking about the thyroid gland. Okay, we are having the colloid formation. Iodinization, deiodinization is happening inside the thyroid follicles, and inside that we are having the colloid formation. So that kind of thing you can remember that here also the thyroidization of the tubules, we are calling that because of the atrophy and hypertrophy of some of the tissues. For example, here you can see the hypertrophy of some of the tubules. I will remove the markings so that you can really appreciate. Okay, so these kind of markings we are calling that thyroidization tubules, and this is seen where? This is seen in the chronic pyelonephritis. I am inserting the image so that you are having the visual memory in your mind. Okay, so that in your paper sometimes you forget about the theories, at least with seeing the terms thyroidization of the tubules, you will be having the diagram in your mind, and that's how you can solve the or crack the question as well. Okay, so that is the main purpose. So thyroidization of the tubules will be seen where? Chronic pyelonephritis. Okay, so remember that. Now let me talk about the other changes about the chronic pyelonephritis. So answer will be very, very clear. You already know that thyroidization of the kidneys will be seen in the chronic pyelonephritis. Now let's talk about the chronic pyelonephritis. So this is the tubulointerstitial renal disorder. First thing, tubules problems are there. Okay, that's why I told you the thyroidization of the kidneys, right? Thyroidization of the tubules mainly. So tubulointerstitial inflammation, you can say tubulointerstitial renal disorder, this is the problem. Okay, now grossly what can be the changes in the acute tubular necrosis? Remember I told you kidney shape will be enlarged, kidneys will be enlarged. Here opposite thing, kidneys are usually small or contracted. Okay, and sometimes the weight of the kidney might reduce lesser than 100 grams. Okay, that is the case. And now surface of the kidney is important. Surface of the kidney is actually irregularly scarred, means like that there will be the irregular surface of the kidney will be appreciated over here, and usually there will be the dilatation of the pelvis and the calyces will be blunted. Dilatation of the pelvis and the calyces will be blunted. All these things will be mentioned in the notes itself. Okay, or you can note down these points by pausing the video and going back again and again. Now microscopic changes will be appreciated as well over here also. What microscopic changes? Many microscopic changes can be seen. For example, in the tubules I told you about the thyroidization of the tubules, atrophy and hypertrophy of some of the areas. In the interstitium there can be the xanthogranulomatous pyelonephritis. Okay, that is actually the uncommon variant, but there will be lymphocyte, plasma cells, macrophages, all these kind of things will be causing the fibrosis in the interstitium. I am calling that as the policeman of these cytokines are working kind of a policeman, so as if they want to see where the accident happened and all these things, right? Pelvic calyceal system, in the pelvis and calyces what will be happening? Renal pelvis and calyces will be dilated. In the blood vessels there will be the scarring of the blood vessels, right? In the glomeruli there will be the periglomerular fibrosis, right? So many changes can be seen in the different levels of the kidneys, but what are the main things? Okay, from as far as chronic pyelonephritis is concerned, in the tubules you should remember the thyroidization of the tubules. In the gross level, surface of the kidney will be irregularly scarred, the kidney will be contracted, weight will be reduced, where the size of the kidney will be reducing, there will be the dilatation of the pelvis, and the calyces will be actually blunting. Okay, these are the home taking points from the chronic pyelonephritis. Rest of the details you can obviously study from the notes itself, which is mentioned in the description box below. Okay, moving on to the next one, autopsy of a woman. 147, autopsy of a woman who died of renal insufficiency has shown unevenly reduced in size kidneys. It can't be the acute tubular necrosis, because in acute tubular necrosis I told you the enlarged kidneys. Here I am talking about the reduced in size kidney. It can be chronic pyelonephritis, however. Now anyways, let's talk for the coarse tuberous surface. On the cut surface, the areas of the healing tissue alternate with the unchanged parenchyma. Renal pelvis are widened with the thick walls. Microscopically, in the wall of renal pelvis, calyces and the interstitium, signs of sclerosis and lympho hypoplastic infiltration. I told you infiltration can be seen, however that can be seen in the acute tubular necrosis also, that may be seen in the glomerulonephritis, that may be seen in the pyelonephritis. That is not the distinguishable point, but how to actually recognize this question that they are talking about the chronic pyelonephritis, because of the unevenly reduced in size kidneys, coarse tubular surface, and main thing over here, reduced in size kidneys, right? I told you the surface of the kidney will be irregularly scarred. Okay, there will be the scarring of the kidney surface. That is the case. Microscopically, they also mentioned that in the wall of renal pelvis and calyces and the interstitium, there are signs of sclerosis. So I told you that there is lymphocytic infiltration. There can be the microscopic change in the tubules, interstitium, blood vessels, pelvic calyceal system, glomerulus. Okay, so many changes can be seen over there, but the main thing is kidney size is reducing, coarse tubular surface, thyroidization of the tubules will be seen. Where? In the chronic pyelonephritis. Isn't it? So that is the case. Okay, fine. 148. If you're interested in more details of the chronic pyelonephritis, of course that will be mentioned in the notes. Okay, in the video itself I can't mention each and every point. Okay, that's why I'm putting that notes in the description box, and main things I'm telling in the video. Okay, 148. Morphological examination of a removed kidney are detected in the proximal part of the ureter. Okay, the kidney has been removed already. Okay, so which means the person have already been dead. Okay, don't worry about that. So proximal part of the ureter, the presence of concrement that obturated its lumen. The kidney is sharply enlarged. with parenchyma atrophy. Renal pelvis and calyces are considerably widened. Microscopically, diffuse sclerosis, atrophy of the glomerular tubules, preserved tubules are cystically widened. What complication they are talking about of the nephrodethesis appeared? Okay, so they itself mentioned that in the removed kidney, proximal part of the ureter, the presence of concrement. Means that some kind of renal stone was there. Okay, that obturated the lumen. Obviously, if that will obturate the lumen, that will cause the obstruction in the pathway of the urine. Okay, due to that kidney sharply enlarged. So what is actually happening? Let's understand that with the help of this diagram, that these are the kidneys. So on the right side, look at the right side. Let's say this is the left. Okay, this is the left of side of the patient, the right side of the patient. Look at the left side of the patient. There is a normal kidney. On the right side, there is hydronephrosis. Normal kidney connecting to what? Ureter, and then normal kidney connecting to what? Ureter, and then there is the urinary bladder. Okay, everything is fine over here. What will be happening? Whatever urine, whatever filtration of the blood, what is the function of the kidney? Filtration of the blood, more specifically filtration of the plasma in the blood, right? So whatever filtration will be happening, that will be converting, that waste substance will be converting itself into the urine, and that will be flowing into the ureter, right? Flowing into the ureter, and will be depositing in the urinary bladder. And whenever you feel, whenever you are having an urge to for the micturition, then the patient will be micturating, right? The patient will be urinating. Now, if the person is having stone, for example, in the proximal part, this is the proximal part. Proximal part means close to the body. Okay, in Hindi you can easily remember. If you don't remember this, proximal means pass, distal means dur. Okay, so if this is the proximal stone, this is the distal stone, let's say, and this in the proximal surface, there is a stone. obturation of the urine will obviously will be happening, obturation. So urine will not be able to pass over here, so urine will be having the backflow in the kidney. If there will be the backflow in the kidney size will be bigger, obviously that will be bigger. And that kind of surface you can see, hydronephrosis, water, this extra amount of urine will be depositing back into the kidney actually, and the rest of the ureter actually. Okay, so that is the hydronephrosis case obviously. So what can be the complication which can be appreciated? So once again let me actually remove the markings so that you can appreciate, right? Yes, so what is that? That is the hydronephrosis case because of this. So if the stone will be present over here, then there will be the hydroureter as well, because here there is no chance of, due to that stone, thanks to that stone, that no urine is coming to the urinary bladder, okay, which actually should have come to the urinary bladder, but here backflow of the urine will be happening, and that will cause hydroureter, and that will cause hydronephrosis, okay, and that will be enough to cause much damage to the kidney and the ureter, okay, and sometimes there can be the hematuria because of this stone obstruction, right? So case is very, very clear that the answer over here will be the hydronephrosis, okay, fine. Moving on, next question, kidneys of a patient who died of chronic renal insufficiency caused by the chronic glomerulonephritis are reduced in size of solid consistence. Capsule can be hardly removed, exposing granular surface. On the cut surface, cortex and medulla are thin, renal tissue is dry, anemic and gray. Okay, so the main thing which they wrote, that is in the last line, that is the renal tissue is dry, anemic and gray. How can we term such kind of kidney? So already the patient is having the history of the chronic renal insufficiency, and he was having the chronic glomerulonephritis. Solid consistency was seen in the kidney. Capsule was very, very hard. What is actually happening on the if on the autopsy, when they cut the kidney, cortex and medulla was very, very thin, renal tissue was dry, anemic and dry. Anemic means there was some kind of deficiency of the red blood cells, right? Obviously. So here the poor kidney was having actually lesser blood supply, and due to that the kidney's shape and size must have been reduced, and they must have been having the gray color. Usually they should have red color, right, because of the blood supply, proper blood supply, but obviously because of some kind of obstruction in the renal artery, that can be the cause. That's why there is the kidney is anemic, isn't it? Let's understand this thing with the help of a diagram. Here is the diagram which you can see on your screen right now. The left kidney is normal, right kidney is having the hard time actually over here. So in the renal, what is the blood supply of the kidney? Very simple, renal artery, isn't it? Renal vein will be draining the blood, renal artery will be entering inside the kidney with the oxygenated blood. Obviously, so if the problem is with the renal artery, if there is some kind of obstruction in the renal artery, for example in this case there is a renal artery stenosis, right? If there is a renal artery stenosis, what will happen? This poor kidney will not be having the proper amount of blood supply, so blood supply will be reduced, isn't it? So blood supply will be reduced over here. So due to that look at the color of this kidney, reddish. Look at the color of this kidney, grayish kind of color, due to the anemia, right? So sometimes what happens is that if the artery is getting older, in older age people, obviously you can understand that that problem can happen actually, and due to some atherosclerotic plaque might exclude the renal artery, and sometimes there's a hardening of the arteries, that is the arteriolosclerosis. That is the most common problem in the older age people, okay, and due to that whatever amount of blood which has to go into the kidney will not be able to go inside the kidney, will not be able to perfuse the kidney properly, so that can also lead to the problem, isn't it? So the main thing, the kidney will be having the hard time over here, so there will be anemic, grayish color. So what will be happening? Yes, the kidney will be contracted due to the lesser blood supply, anemia, anemic and gray kidney, due to the arteriolosclerosis, mainly arteriosclerosis, hardening of that artery. Hardening of the artery is the most common cause over there, and that is the cause, and sometimes renal artery stenosis may happen due to that. So arteriolosclerotic kidney, arteriosclerosis might happen, okay. So that was about the discussion of the kidney, and before that we have already talked about the liver as well. So we have talked about decent amount of topics, decent amount of concepts, and I believe that if you listen to this video again and have some proper notes about these topics: chronic pyelonephritis, chronic glomerulonephritis, acute tubular necrosis, what is the concept of the atherosclerosis, arteriosclerosis, hydronephrosis, as far as the liver is concerned, what is the concept of the liver cirrhosis, portal hypertension, what is the concept of the viral hepatitis. Please go through these topics, they are very hot topics. As far as liver and kidney is concerned, these are the main topics which you need to hammer on, which you need to focus on. Okay, so I wish you all the best, and if you enjoyed the discussion, if you're enjoying the discussions, please give your reviews in the comment section below. If you have enjoyed this video, and please hit the like button, make sure you subscribe the channel, and if you're liking the videos, please share it with your friends as well. And as always, I will see you in the next video with the discussion of the endocrine system pathology. Till then, take care. I will see you in my next one. Thank you so much for watching this video. Bye.